Hello, I'm Dr. Suraj Panchal. Today, in this session, I'll be dealing with antipsychotic agents part 2. Initially, in my antipsychotics agents class with the part 1, I initiated with the anatomical basis and the physiological basis, of antipsychotic agents so as to integrate with the pharmacology proper. So in the initial classes, we discussed about the dopaminergic pathway and its relevance to the antipsychotic agents and the schizophrenia. I hope uh, the initial class will act as a bridge for better understanding of the antipsychotic agents proper. So let me continue this class in this way. That is, first I will be starting with the classification proper, then basic pharmacology of antipsychotic agents, the pharmacokinetics and its clinical importance, pharmacodynamics of the antipsychotic agents and its relevance to the adverse effects, and then adverse effects in general. Now, based on the inputs from the previous discussions from the YouTube, I got an input so as to share few of the lines or the from the notes. So therefore, I thought why not to share notes in the form of some pictures in the PPT. So I thought to share a few. Uh, this is how it goes. Coming on to the classification of the antipsychotic agents, they are basically divided into two types. That is typical, or also known as conventional or the first generation antipsychotics, and the other type is known as atypical or the second generation. Now if you see the typical, they acts by blocking the D2 receptors, and that's why they are called as conventional. But however, it comes with a side effects potential of increased extrapyramidal symptoms and high tendency of causing hyperprolactinemia. Okay, now why they are called as atypical or the second generation is the reason. If you see the mechanism, it is different from that of the conventional. That is, this atypical acts by blocking the subtype of serotonin receptors predominantly with a higher affinity towards 5-HT2A receptors when compared to dopamine receptor. That's the reason it is called as atypical antipsychotics. The other reason why they're called as atypical, if you see the affinity potential, since there is a lesser potential to block the D2 receptors with respect to atypical, so therefore there is a lesser chances of extrapyramidal symptoms, as well as the lower potential or a tendency to cause hyperprolactinemia. So therefore the other reason why they are called it as an atypical antipsychotics. Now coming on to the subclassification of the typical or the first generation antipsychotics, chemically they are divided into three: phenothiazines, thioxanthines, and butyrophenones. In the phenothiazines, chlorpromazine, it's a prototypic typical antipsychotic drugs. Thioridazine, this is the importance is they are a low potent typical antipsychotic drugs. So the importance of low potency is they have a higher tendency of blocking histaminic receptor, that is subtype H1, alpha 1, and then muscarinic receptors. The other examples which belongs to phenothiazines are trifluperazine, flufenazine, and perfenazine. Also remember, for our undergraduates, it is not that important to remember low potency and high potency, but of course it acts as a bridge for preparing the entrance examination. So therefore, yeah, it's better to start with the second year preparation itself to divide how to remember the classification in a way like low potency, which has a higher tendency of blocking H1, alpha 1, and M1, and then trifluperazine, flufenazine, and perfenazine, that is high potency drugs, they have lesser tendency to block the H1, alpha 1, and muscarinic receptors. Thioxanthines, flupentixol, thiothixine, that is once again a high potency antipsychotic drug. Butyrophenone, the classical one, haloperidol, once again it's a high potency, that is low amount of drug is required to block the dopamine 2 receptors. That's the whole idea. Okay. In the miscellaneous, pimozid, that is a high potency drugs. Loxapine, that is an inhaled form, that is only typical antipsychotic which is available in inhalation form. And molindol, for the entrance, till date they haven't asked, but a prospective question can be: it is the only antipsychotics which with the potential of causing weight loss. Okay, that's the importance of this miscellaneous agent, that is molindol in the first generation. Coming on to the atypical or the second generation, The clozapine, it's a prototypic atypical agent, and olanzapine, followed by quetiapine, loxapine, and acinapine, zotipine. So these are all pines. Then we have dones like risperidone, paliperidol, it's a metabolite of risperidone, ziprasidone, iloperidone, aripiprazole, cariprazine, and the most recent advanced one is the pimavanserin. Now let us understand the basic pharmacology of antipsychotic agents. To be more precise, the typical antipsychotic agents, why they are called typical or the conventional, basically they act by blocking the D2 receptors. So therefore, once they block the D2 receptors, they have a higher chances of causing extrapyramidal symptoms. That is, the dopamine receptors present on the dorsal striatal of the nigrostriatal pathway increases the cholinergic activity in the central, therefore leading on to the higher tendency of extrapyramidal symptoms. Now, if you see once again the importance of a high potency and low potency, high potency drugs of typical antipsychotics, they have definitely a greater tendency of causing extrapyramidal symptoms. Simply the reason being they have a higher affinity for the D2 receptors. So therefore, the higher chances. Once again, the higher potency drugs like haloperidol, they have a lesser blockade effect on the histaminic receptor, that is H1, adrenergic receptor, that is alpha 1, and muscarinic receptor subtype, that is M1. So therefore, if you see the net effect, you will see that there are lesser chances of autonomic side effects with respect to high potency drugs when compared to the low potency drugs. So low potency drugs, they have the other, in a way, they have a greater blockade effect on the H1 receptor, which is responsible for causing sedation and weight gain as a side effect. Greater alpha 1 blockade effect, therefore you will see orthostatic hypotension and palpitation as a side effect. And then you will see, because of the M1 blockade, you will see some of the anticholinergic side effects in the form of dry mouth, urinary retention, and constipation. So this is the importance of knowing the basic pharmacology of antipsychotic agents. Let us see the atypical one. Why they are called atypical, we have already seen the reason for the fact that they have a higher affinity to 5-HT2 receptors than the D2 receptors. Therefore, the lesser chances of extrapyramidal symptoms and lesser chances of hyperprolactinemia. The reason why they have a lesser extrapyramidal symptoms, we'll see with this explanation. There are two explanations for this, for having a lesser extrapyramidal symptom. Let's us see the first one. Normally, the 5-HT2A stimulation present on the cortical pyramidal neurons, they are responsible for stimulating the glutamate release in the brainstem. Okay, this we already discussed in the initial classes. Increased glutamate or glutaminergic signaling on the GABAergic neurons, it triggers the GABA release, which normally has an inhibitory influence on the dopaminergic neurons. So therefore, it inhibits the dopamine release in the striatum. This is how normally it happens. So what happens once you give a blockade of 5-HT2A receptor, that is in the form of atypical antipsychotics, you will see that the net effect will be increase in the dopamine release, that is endogenous dopamine release. Now what happens once there is an increase in the dopamine level, it try to compete for the dopamine antagonist. Okay, so therefore once it competes for the D2 antagonist, it decreases the D2 receptor binding to the extent that below the 80%. Why there is an importance of this value is, it's been seen that whenever there is a occupancy of D2 receptor more than or equal to 80%, they have a higher tendency of causing extrapyramidal. So therefore you will see that this endogenous dopamine will compete, making it to occupy less than 80%, and therefore lesser chances of extrapyramidal symptom. This is one of the reason for lesser chances of extrapyramidal symptoms with the atypical antipsychotics. Let us see the second explanation for the same, that is lesser tendency of extrapyramidal symptoms, that is 5-HT1A, that is a subtype of serotonin receptors with partial agonistic activity. So therefore, we'll see some of the importance of this 5-HT1A physiological importance. 5-HT1A subtype receptor of serotonin present on the cortex, when stimulated by the serotonin, normally inhibits the glutamate release. So this effect decreases or inhibits the release of GABA, which in turn loses its influence on the dopaminergic neuron, thereby increases the dopamine release in the striatum, thereby decreasing the tendency of extrapyramidal symptoms. So therefore, I would like to highlight once again, it is the importance of 5-HT1A partial agonism. That is, those drugs which have this property are in the atypical antipsychotics like clozapine, quetiapine, aripiprazole, brexpiprazole, and cariprazine. You will see that these are the drugs which have a lesser tendency of causing extrapyramidal symptoms because of the property it gains because of 5-HT1A partial agonism. The other reason why it is called as an atypical antipsychotic is its lesser tendency to cause hyperprolactinemia. So normally what happens is, what is the reason for this lower tendency of hyperprolactinemia is, normally the 5-HT2 receptors, it increases the prolactin release. If you see, unlike the dopamine, which normally inhibits the prolactin release, however, normally the 5-HT2A stimulation increases the prolactin release. So therefore, upon 5-HT2A inhibition by the atypical antipsychotic agents, it decreases the prolactin release. So therefore, it has a lesser tendency of causing hyperprolactinemia. That's the reason, that's these two reasons why they are called once again as an atypical antipsychotics. Now coming on to the pharmacokinetic importance in general, absorption in general, if you see most of the drugs, they have a significant first pass metabolism and they have most, incomplete absorption. Coming on to the importance of distribution, most of the drugs have a plasma protein binding capacity between 92 to 99%. And they are highly lipid soluble in nature with a volume of distribution more than 7 liters up to 20 liters of some of the drugs per kg. Now, what is the importance of this is, this makes drug to be of longer duration of effect, longer acting. So another reason why most of the drugs are longer acting, and for that fact they are given once in a day, is they also have a tendency to occupy the D2 receptor for longer duration. Okay, so that's the reason of knowing the importance of this distribution. Now, coming on to the clinical importance of this, kinetics importance. Now, it's been seen that when the average time for the relapse is, 3 to 6 months for most of the drugs, because they have a higher tendency, of binding to the D2 receptors for the longer duration, and also the fact that higher volume of distribution. So therefore, even after discontinuation, the relapse it takes is for 3 to 6 months, except for the clozapine, there is a rapid relapse. So therefore, clinically, it becomes important not to stop abruptly the clozapine. And therefore, it's unless otherwise, if there is an emergency condition like myocarditis and agranulocytosis for the clozapine, it should never be stopped abruptly. This was never tested anyways. A few important points to be highlighted. The highest placental passage ratio can be a MCQ question. It has been seen with the olanzapine, that is 72%. Risperidone, it has 47%, sorry, and then haloperidol, which has 42% placental passage ratio. Now coming on to the in general, the metabolism, it is mostly metabolized by CYP system, and which with subtypes including 2D6, 1A2, and 3A4. Now coming on to the pharmacodynamic part, with the typical antipsychotic agents, as we saw that it mostly acts by blocking the D2 receptors. Coming on to the importance of the mesolimbic pathway, we have already discussed in the initial antipsychotic part 1 discussion that there is an increase in the mesolimbic pathway in the schizophrenia, which is responsible for increased dopamine activity, which is responsible for the positive symptoms in the schizophrenia in the form of delusion and hallucinations. So therefore, typical antipsychotic agents, by blocking the D2 receptors on the mesolimbic pathway, they reduces the positive symptoms. So therefore, the reason why typical antipsychotics may be justified for the application in the those patients which have high tendency of positive symptoms. Let us see the importance of D2 blockade and the mesocortical pathway. Now, this is the bad part of the typical antipsychotic. It's been seen that some of the typical antipsychotic, they can worsen the negative symptoms and they may cause the cognition impairment for the reason that they act by blocking even the D2 receptor which are present on the mesocortical pathway. Now, it's been already seen that in the schizophrenia, there is already a decreased mesocortical activity. Upon that, if there is a blockade of D2 receptor by the typical antipsychotic, it may even worsen the negative status or the negative symptoms, and the further cognition impairment can be seen with the typical antipsychotics. So, therefore, the reason these days they starts with the atypical antipsychotics, which have a important role in the negative symptoms. Coming on to the other importance of dopamine D2 of blockade, that is D2 present on the nigrostriatal pathway, they are responsible for controlling the motor activity. So this is not distinguished by the typical antipsychotics. So therefore, even if it blocks the mesolimbic, sometimes even it can block even mesocortical D2 receptors or the nigrostriatal D2 receptors, ending up with the presentation of extrapyramidal symptoms. Coming on to the other importance of typical antipsychotic agents, the dopamine 2 receptor blockade on the tubular infundibular pathway are responsible for increasing the prolactin secretion, which is responsible for galacturia in women and gynecomastia in men. Now, if you see physiologic, in the last discussion, we discussed that the dopamine released from the dopaminergic pathway of tubuloinfundibular pathway, it normally inhibits the prolactin release by acting on the lactotropes in the anterior pituitary. So therefore, naturally, upon blockade of D2 receptor, there is an increase in the prolactin secretion. There is a higher density of the dopamine receptors on the area prostema, which is responsible for emetic signaling. So therefore, upon D2 blockade by the typical antipsychotics, it has a potential with anti-emetic property. So therefore, you will see that some of the uses of typical antipsychotics as an anti-emetic role. Let us see the importance of receptor occupancy at the level of D2 receptor. Now, it's been seen that for efficacy or a response to a drug, especially a typical antipsychotics, as good as 60% of the D2 receptor has to be occupied in order to produce efficacy or a response to a drug. But for atypical, it is sufficient for a drug to occupy only 30 to 50%. Okay, why is it fact? We saw that the atypical antipsychotic, they basically act by having a higher affinity towards the 5-HT2 receptor. Therefore, only 30 to 50% occupancy at the D2 is sufficient for causing, its effect on the schizophrenic patients. But however, if you see, for extrapyramidal symptoms to produce, the occupancy of the drug at the level of D2 receptor should be more than or equal to 80%. Okay. That is the importance of this D2 receptor occupancy. Now coming on to the atypical pharmacodynamic part, yes, we saw that it basically acts by blocking the 5-HT2 receptor and the D2 receptors with a higher affinity towards the 5-HT2A. You'll see that some of the atypical antipsychotics, they also acts by 5-HT1A partial agonistic activity. Coming on to the adverse effects in general, now let us divide it into system wise. Coming on to the first, that is neurological. In the neurological, it is extrapyramidal symptoms, obviously because of the D2 receptor antagonism. And in the neurological, we will see some of the early and late side effects or the adverse effects of typical antipsychotic agents. So therefore, for an entrance point of view, it is important to remember which among the following is an early neurological side effect or the late adverse effects of the typical antipsychotic agents. Now, one of the example of the early adverse effect is acute muscle dystonia, which presents as the spasm of muscle of tongue, face, and neck. If you see the time duration, once again, it can be an important point to remember. It is started between 1 to 5 days after initiation of the therapy. It is as early as starting off within 1 to 5 days of therapy, and usually seen in the younger population and those who are new to the treatment, that is treatment new patients. And the mechanism which is attributable for this is acute DA antagonism. So therefore, you will see that the treatment strategy obviously would be because of the D2 antagonism, there is an increase in the central cholinergic activity. So therefore, by blocking the central cholinergic receptor, that is by giving the centrally acting anticholinergic drugs in the form of benztropine, bipyridine, procyclidine, and then diphenhydramine. So these are the treatment of choice in the acute muscle dystonia, which are induced by the D2 receptor blockade. However, diphenhydramine is an first generation antihistaminic with anticholinergic property. The second early side effect of antipsychotic agents are akathisia, which usually presents in the form of restlessness with no anxiety. It starts within 5 to 60 days of initiation of the therapy, and the mechanism is not clearly known here. And this treatment strategy for akathisia is to reduce the dose of antipsychotic agents or the change the typical to the atypical. And however, the drug of choice for the akathisia is propranolol, that is a non-selective beta blocker. The other drug which may be of helpful is benzodiazepine, that is clonazepam. The third early side effects of antipsychotic agents are drug-induced Parkinsonism. Why it is called Parkinsonism? For the fact that it presents the features similar to that of Parkinson's disease in the form of bradykinesia, rigidity, and tremors. It is started within the initiation of 5 to 30 days, and then it is mostly seen in the elderly patients, and the mechanism which is once again attributable is for the reason that is DA antagonism at the level of nigrostriatal pathway, which is responsible for which is normally responsible for controlling the motor activity. So therefore we'll see some of the changes in the motor system. So therefore the treatment strategy obviously is to either reduce the dose of a drug or change the medication from typical to atypical antipsychotics, that is they have a lesser tendency of blocking the D2 receptors, hence the reason. And then since there is an increased central cholinergic activity, therefore once again central anticholinergic drugs comes into picture, and it mostly improves the tremors and the rigidity component of the Parkinsonism. However, this anticholinergic may have even peripheral side effects. So therefore, to avoid that anticholinergic side effects, amantadine can also be used, which increases the dopamine level by its mechanism, that is dopamine reuptake blockade. Coming on once again, early side effects of typical antipsychotic agent, that is neuroleptic malignant syndrome. However, it is very rare. And however, you will see the features like in the form of increased muscle activity, rigidity, which is responsible for fever, unstable blood pressure, release of myoglobin, leading on to the myoglobinemia, to the extent that it can cause nephrotoxicity and hence renal failure. So this is usually starts within the initiation of antipsychotic agents, and the timing is usually between the weeks and months of start of therapy. And once again, the mechanism attributable here is dopamine antagonism. So therefore, obviously, the treatment strategy would be to stop the antipsychotic agents immediately, to give supportive care in the form of, to reduce the hypothermia in the form of a tepid sponging or cool sponging, to maintain the electrolyte balance, to maintain the blood pressure. And there are some other drugs which may be of useful, that is dandrolene, diazepam, and bromocriptine. Though the dandrolene is a drug of choice in the malignant hyperthermia, it has some role in the treatment of even in the neuroleptic malignant syndrome, though it is not a ryanodine receptor as a mechanism for the neuroleptic malignant syndrome, but still dandrolene it's been seen that it has some role in the treatment of neuroleptic malignant syndrome. Let us see the late side effects of typical antipsychotic agents, tardiodyskinesias. So one of the most common movement disorder associated with tardiodyskinesia is orofacial dyskinesias, and rarely the worst part of the dyskinesia is the chorioathetosis or the dystonia. Now it's usually seen between months or years of treatment of antipsychotic agents, with the elderly population as a risk population, and although it is seen in those patients who take the high potency first generation antipsychotics. For the obvious reason, these have a higher D2 blockade, so therefore the chances of causing tardiodyskinesias in this set of populations is more. What exactly is the mechanism here is, whenever the D2 antagonism is given for years together or months together, they tend to cause super sensitivity of the receptor or the upregulation of the existing dopamine receptor postsynaptically. This is the reason for the dyskinesias. What is the treatment strategy for the tardive dyskinesias? Is to stop the typical antipsychotic agents and to shift to the atypical antipsychotic agents. The most often used is clozapine. It's been seen that clozapine has the least tendency to cause tardive dyskinesias. The reason being it has a partial agonistic activity at the level of D2 receptor. You will see that it is only one of the few drug which has a partial agonistic activity at the level of D2 receptor among entire antipsychotic agents. However, in case of refractory cases of the tardive dyskinesias, tetrabenazine is a choice and it acts by blocking the vesicular monoamine transporter 2, which is present on dopaminergic neurons. So therefore depletes the dopamine and therefore the dyskinesia is associated with it. However, the other drugs which may be of helpful are anticholinergic drugs and botulinum injection. The other late side effect of antipsychotic agents are perioral tremors, also known as rabbit syndrome. The timing of onset of this presentation is between months or years of treatment of antipsychotic agents. The mechanism is not known, however, and some drugs which may be of useful or amantadine or anticholinergics. Coming on to the few other adverse effects associated with other systems are, let us see in eye. It's been seen that there are few deposits in the cornea and lens, which is usually seen with a drug chlorpromazine, which is a prototypic first generation antipsychotic drug. Pigmentary retinopathy, thioridazine, once again can be an MCQ question because not all the therapeutic dose, only if more than or equal to 800 milligram per deciliter of thioridazine have higher tendency of causing pigmentary retinopathy and cataract formation. Usually the drug associated is quetiapine. In the cardiovascular system, there is a tendency to cause the prolongation of the QT interval, and the reason or the mechanism is attributable to by inhibiting the delayed inward rectifying potassium channel. And the drugs which have the tendency of blocking this potassium channel and hence prolonging the QT interval are thioridazine, that is low potency first generation antipsychotic, ziprasidone, and pimozid. Coming on to the endocrine side effects, let us see, this is one of the high weightage adverse effect, most likely for the entrance once again. You will see that normally the serotonin and the histamine, they have the effect of anorexia by acting on the hypothalamus, that is on centrally. Now what happens, there are some drugs which acts by blocking the H1 receptor, therefore can cause increase in appetite and hence the weight gain. Let us see what are those drugs. It's been seen that it has been prominent with the clozapine and the olanzapine, and it has the maximum tendency among the atypical antipsychotics to cause the weight gain, and very low with aripiprazole and ziprasidone among the atypical antipsychotics. Among the typical antipsychotic agents, the weight gain is maximum with the low potency antipsychotic agent, that is chlorpromazine. Now coming on to the dyslipidemia and the new onset type 2 diabetic mellitus as an adverse effect profile of the antipsychotic agents. In dyslipidemia, you will particularly see that the triglyceride component is increased, which is attributable to there is an increase in the insulin resistance. The mechanism is not known because there are a lot of serotonin receptors which are involved here, which increases the lipolysis, which increases the free fatty acid, which acts as a source for the increase in triglyceride level. Okay, it is the triglyceride component which is increased in the dyslipidemic features, and it's been seen that all the atypical antipsychotic agents have higher tendency of causing dyslipidemia and newer onset type 2 diabetes, except ziprasidone, acinapine, and aripiprazole. Once again, an MCQ importance. However, it has been seen maximally with the clozapine and olanzapine among the atypical antipsychotics, and among the typical antipsychotics, the maximum tendency is seen with low potency drugs like chlorpromazine and the thioridazine. The other endocrine changes are in the form of increase in prolactin level, which is responsible for galactaria and amenorrhea to the extent of infertility in women, and gynecomastia and decreased libido in men. The reason for this is obviously because of the D2 blockade, and the maximum tendency is seen with haloperidol among the typical, and among the atypical it is the risperidone and the paliperidone. Now coming on to the autonomic effects, M1 blockade causes dry mouth, constipation and urine retention. And among the typical antipsychotic agents, you will see that low potency drugs, which we already discussed, they have a higher tendency of blocking M1 receptor. And then among the atypical antipsychotic agent, it is the clozapine. You will see one of the side effects of clozapine as an constipation, for the reason that because of its tendency to block the M1 receptor. Alpha 1 blockade are responsible for the orthostatic hypotension and then the palpitation. Among the typical antipsychotic agents, once again, the low potency drugs like chlorpromazine, and among the atypical antipsychotics, that is clozapine and iloperidone. So in order to improve the orthostatic hypotension, one of the drug with the mineralocorticoid property may be of helpful, that is fludrocortisone. Let us see other side effects, that is immune mediated. One of the emergency adverse or emergency condition which can arise due to clozapine is agranulocytosis. Okay, the incidence for this is less than 1%, and the highest risk is seen within 6 months of initiation of this therapy, and therefore it becomes an important to monitor the complete blood count initially to rule out the agranulocytosis induced by clozapine. So therefore this is an indication never to restart a drug when clozapine induces agranulocytosis. That's we call it as a never re-challenge a drug. Never re-challenge is to never restart a clozapine once this side effects arises because of clozapine. Sedation, it is attributable to the blockade of H1 receptors, and it is maximally seen with chlorpromazine, which is a low potency drug. And among the atypical, it is clozapine and quetiapine. You will see one of the side effects of clozapine as a sedation. Seizures, however, the US FDA warns for all the antipsychotic agents as seizure as a warning label. But however, the tendency is mostly seen with clozapine with the incidence of 3 to 5% per year, and olanzapine less than 1%. However, the mechanism is not clearly known, and the drug used for the treatment for the drug-induced seizure, that is typically with the clozapine, use the valproate. Now the question arises, why not phenytoin and the carbamazepine? Is phenytoin and carbamazepine, they are enzyme inducers, therefore it can reduce the efficacy or of the antipsychotic agents, therefore it can worsen the presentation of schizophrenia. And also the fact that carbamazepine, they have a harmful effect on the bone marrow, that is it can inhibit the bone marrow effect, so therefore it can once again sometimes can worsen the leukopenia status of clozapine, that is agranulocytosis. So therefore you will see that valproate, it acts by multiple mechanism, will become an obvious choice for the treatment of seizures because of antipsychotic agents, in particular to the clozapine. So that's all from this session. I hope you will better understand this class when you start integrating my class on the antipsychotic agents part 1. Thank you. Please share and subscribe for the further notification, and if there are any suggestion on the comment, you are welcome for the same. Thank you.